Hello friends, welcome back to our channel GYRI and Sulci. Today we shall be discussing about an interesting topic of thiazides. So first of all, let's take a look at its members. They are as follows: chlorthalidone, hydrochlorothiazide, indapamide, metolazone, zepamide, and clopamide. Generally act on early distal tubules where they block the sodium chloride cotransporter. The sodium chloride cotransporter is a glycoprotein with 12 membrane domains which ultimately causes increased excretion of sodium, chloride and water and hence cause diuresis. And we will discuss about its mechanism a few moments later. In this lecture, I shall be denoting the sodium chloride cotransporter as NCC, distal tubule as DT, and proximal tubule as PT for our convenience. So, these thiazide group of drugs reach their site of action by acid secretory pathways in the proximal tubule, from where they move along the lumen to reach the distal tubule. In distal tubule, they block the NCC, thereby causing diuresis. By blocking this sodium chloride cotransporter, the thiazides also reduce the positive free water clearance as the tubular fluid is not maximally diluted. We will learn about the concept of free water clearance in the part where we will talk about the uses of thiazide group of drugs. Thiazides also do not affect the corticomedullary osmotic gradient as they do not act on any part of loop of Henle. The thiazides are also known as medium efficacy diuretics as the sodium chloride cotransporter accounts only for 5% of sodium reabsorption. Therefore, most of the sodium is reabsorbed before reaching the distal tubule and hence thiazides produce a mild diuretic effect. Because of the tendency to reduce the blood volume as well as due to intrarenal hemodynamic changes, thiazides tend to reduce the GFR significantly. Therefore, they cannot be used in person with low GFR. Now, in order to understand the mechanism of action of thiazides, let's first take a look at normal reabsorption mechanism occurring in distal tubules. This thiazide-sensitive sodium chloride cotransporter is responsible for drawing sodium and chloride ions into the cell. Now, 3 sodium ions are pumped outside into the blood for every 2 potassium ions entering into the cell through the sodium-potassium ATPase pump. And this chloride ion also enters the bloodstream through this chloride-sensitive channel present on the basolateral membrane of the ductal tubular cell. Now moving on to the mechanism of action of thiazide group of drugs. This cotransporter is the target of action for thiazides. The thiazides block the activity of this cotransporter which blocks the reabsorption of sodium and chloride into the cell. Now consequently, more sodium and chloride ions accumulate within the lumen. And as we all are well acquainted with the fact that wherever sodium goes, water follows, so more and more water is drawn into the lumen, which ultimately leads to increased excretion of sodium and water along with chloride ions in urine and thereby causing diuresis. Now we know that there is reduced sodium concentration within the epithelial cell. This reduced sodium concentration increases the driving force for net entry of sodium into the epithelial cell, and this causes increased outward movement of calcium into the blood. Now, because of this, calcium concentration reduces within the cell. This reduced calcium concentration within the cell becomes the driving force for enhanced reabsorption of calcium from the filtrate. Now these extra calcium ions are pumped into the blood, causing an increase in blood calcium level. Therefore, thiazide act to improve the bone density and also reduces the risk for calcium renal stones by increasing the reabsorption of calcium from lumen into the blood. Now downstream in the distal tubule, a passive sodium hydrogen and potassium hydrogen exchange occurs. The sodium gradient present between the lumen and the cell governs this exchange, as more amount of sodium is present within the lumen due to inhibition of sodium chloride cotransporter upstream, and this results in higher driving force for sodium to move inside the cell. As more and more sodium moves into the cell, it makes the luminal charge relatively more negative and draws the positively charged potassium ion and hydrogen ion. Now, as these ions enter the lumen, they both will be excreted out via urine. Now, as this causes a net loss of potassium and hydrogen ion from the body, it would lead to hypokalemia and alkalosis, respectively. Now, as the extracellular fluid volume is reduced significantly due to diuretic effect of thiazides, it increases the urate reabsorption from proximal tubule, which cause a slight increase in blood urate. And the long-term increase in the blood urate might precipitate the attack of gout. Thiazides also cause a slight increase in blood sugar as it causes hypokalemia. This reduces the insulin release from the pancreas, which causes hyperglycemia. Now a doubt must be striking your minds. You must be wondering that the sodium is reabsorbed in this part of tubule, then how it will produce diuretic effect? The answer is simple. The amount of sodium that is accumulated in the lumen due to blocking of sodium chloride cotransporter is very high than the amount of sodium that is being exchanged here. Therefore, it will produce diuretic effect as well as causes hypokalemia and alkalosis. Now, coming to indication or uses of thiazides, one thing that must strike your mind whenever someone asks you about the uses of thiazides is control of hypertension. They are mild antihypertensives which prevent fluid retention and also help in overcoming the resistance. They are more cost effective than other antihypertensives and also show low incidences of postural hypotension. They act so by causing diuresis, which leads to a decrease in plasma volume as well as extracellular fluid volume, which causes a reduction in venous return, which causes ventricles to pump less blood, thereby decreasing the cardiac output, and this is reflected in the form of reduced blood pressure. Thiazides also cause vasodilation of visceral vessels, which reduces the total peripheral resistance, thereby causing a further decrease in blood pressure. Seventh Joint National Committee on Prevention, Evaluation, and Treatment of High Blood Pressure recommends low-dose thiazide therapy in combination with potassium-sparing diuretics as most effective therapy for treatment of essential hypertension in elderly. Thiazides can also be used in several cases of edema. However, their use is restricted here as they are used as maintenance dose for mild to moderate cases of edema. Here, the drug of choice remains the loop diuretics as they cause rapid mobilization of fluid present within the cavities. They are only effective in the cardiac edema and cannot be used in hepatic or renal edema. Thiazides are also indicated in several cases of diabetes insipidus. They do so by causing a reduction in positive free water clearance. Now, you must be wondering, what is this positive free water clearance? Pay attention as this concept is unknown to most of you. The positive free water clearance means the amount of water that stays in the lumen without solute in any part of nephron. Now understand how thiazide causes a reduction in this positive free water clearance. Thiazides blocks the normal sodium chloride cotransporter. Therefore, there is decreased absorption of sodium and chloride. This causes increased concentration of sodium and chloride within the lumen. Therefore, the solute concentration within the lumen increases, which causes a reduction in free water clearance. This causes the filtrate to become more diluted, and this dilution helps in rectification of diabetes insipidus. Now, the final use of thiazides is hypercalciuria. As we know that thiazides increase calcium reabsorption from the lumen, thereby causing a decrease in calcium excretion via urine. This reduces the risk of precipitation of calcium renal stones. Now, coming to adverse effects, Most of the adverse effects are due to fluid and electrolyte imbalance caused by thiazides. The first and the most significant problem caused by thiazides is hypokalemia. It is a consequence of brisk diuresis, which occurs especially if the dietary potassium intake is low. It presents itself as weakness, fatigue, muscle cramps, or in serious conditions as arrhythmias. The treatment for hypokalemia is increased dietary intake of potassium, KCl supplementation, or concurrent use of potassium-sparing diuretics. These two are used in special risk conditions such as in cirrhotics, in cardiac patients, or when a patient is on digitalis medication. The most efficacious of these all is the use of potassium-sparing diuretics. KCl supplementation is not recommended with diuretics as it might precipitate gut ulceration due to potassium release as a single spot. Therefore, the potassium-sparing diuretics are the treatment of choice for hypokalemia caused by thiazides. Thiazides may also cause alkalosis with hypokalemia as we have discussed earlier. Prolonged therapy with thiazides may also cause a rise in blood urate which might further precipitate as gout. It can be treated by use of allopurinol. Thiazides may also cause mild hyperglycemia and hyperlipidemia. It occurs when high-dose thiazides are used as antihypertensives. This is due to the fact that prolonged use of thiazides as antihypertensives may cause hypokalemia, which decrease the insulin release from the pancreas, therefore causing hyperglycemia and hyperlipidemia. Another adverse effect of thiazides is hypercalcemia. It occurs as calcium reabsorption in the body increases, leading to decreased calcium excretion, and this reduces the risk of precipitation of calcium renal calculi. Prolonged use of thiazides may also cause magnesium depletion within the body. This can increase the risk of ventricular arrhythmias. This condition can be treated with the use of potassium-sparing diuretics. Thiazides may also activate renal insufficiency as they reduce the GFR. They also cause several gastrointestinal disturbances which manifest as nausea, vomiting, and diarrhea. Thiazides also cause certain nervous disturbances such as headache, weakness, paresthesias, and impotency. They also manifest several allergic reactions such as rashes and photosensitivity. Thiazides are contraindicated in cases of severe oliguria or anuria, which are manifested in the person suffering from acute kidney disease. They are also contraindicated in hepatic disease such as cirrhosis. They aggravate electrolyte imbalance, so they cannot be administered to a person who is already suffering from electrolyte balance. They are contraindicated in pregnancy. They are also contraindicated in the cases of renal insufficiency as they further decrease the GFR. As they also cause hyperglycemia, they are also contraindicated in cases of uncontrolled diabetes mellitus. That's all for today, folks. Hit the like and subscribe button, post your queries in the comment section, and stay tuned for amazing content lined up for all of you.